Welcome to today's comprehensive lecture on childhood leukemia, brought to you by Pediatric Case Review. I'm excited to guide you through this advanced exploration of pediatric leukemia, covering everything from epidemiology to the latest treatment protocols. Throughout our session, we'll examine real-world clinical cases to enhance your diagnostic and management skills. This presentation is designed specifically for healthcare professionals working with pediatric oncology patients. Let's begin our journey into understanding this challenging but increasingly treatable condition. Let's start with our first case. A 4-year-old boy presents with pallor, petechiae, and low-grade fever for 3 weeks. Based on this presentation, which of the following is most accurate regarding childhood leukemia epidemiology? A. Acute myeloid leukemia is more common than acute lymphoblastic leukemia in children. B. Peak incidence of all occurs between 2 to 5 years of age. C. There is no gender predilection in childhood at all. D. The incidence of childhood leukemia has decreased over the past 2 decades. The correct answer is B. The peak incidence of acute lymphoblastic leukemia indeed occurs between 2 to 5 years of age. This is an important epidemiological feature to remember. ALL is the most common childhood leukemia, accounting for approximately 75 to 80% of cases, while AML is less common. Contrary to option C, there is a gender predilection with males having a slightly higher risk than females, with a ratio of approximately 1.3 to 1. And regarding option D, epidemiological studies have shown that the incidence of childhood leukemia has remained relatively stable or even slightly increased in some populations over recent decades. Moving on to our second case. A 3-year-old girl with Down syndrome presents with easy bruising and fatigue. Which genetic syndrome is associated with the highest relative risk of developing leukemia in childhood? A. Neurofibromatosis type 1. B. Down syndrome. C. Bloom syndrome. D. Fanconi anemia. The correct answer is B. Down syndrome carries the highest relative risk among the listed genetic syndromes. Children with Down syndrome have a 10 to 20-fold increased risk of developing leukemia compared to the general population. Approximately 1 in 150 children with Down syndrome will develop acute myeloid leukemia during the first 5 years of life. They have a particular predisposition to develop acute megakaryoblast leukemia, a specific subtype of AML strongly associated with trisomy 21. While the other listed conditions, neurofibromatosis type 1, Bloom syndrome, and Fanconi anemia, all increase leukemia risk, none elevate it to the same degree as Down syndrome. Let's examine our third case. A 6-year-old presents with fatigue, bruising, and a white blood cell count of 85,000 with 90% blast cells. Cytogenetic testing is pending. Which chromosomal abnormality is associated with the most favorable prognosis in childhood acute lymphoblastic leukemia? A. T922, also known as Philadelphia chromosome. B. T1221, resulting in ETV6 RUNX1 fusion. C. T411, which is an MLL rearrangement. D. Hypodiploidy, which means fewer than 44 chromosomes. The correct answer is B. The translocation 1221 resulting in ETV6 RUNX1 fusion is associated with the most favorable prognosis among these options. This genetic abnormality is present in approximately 25% of pediatric B-cell acute lymphoblastic leukemia cases and is associated with an excellent prognosis, with cure rates exceeding 90%. In contrast, the Philadelphia chromosome, or T922, and MLL rearrangements found in T411 are both associated with poor prognosis and often require more intensive therapy. Similarly, hypodiploidy with fewer than 44 chromosomes is also considered a poor prognostic factor in all as mentioned in the notes provided, with significantly lower survival rates compared to other cytogenetic profiles. Now for our fourth case. A 5-year-old boy presents with fever, fatigue, and pallor for 2 weeks. On examination, he has cervical lymphadenopathy and hepatosplenomegaly, which finding on general examination would be least likely in a child with newly diagnosed leukemia. A. Multiple bruises. B. Tachycardia. C. Jaundice. D. Pallor. The correct answer is C. Jaundice is not a typical presenting feature of childhood leukemia. According to the clinical information provided, children with leukemia typically present with pallor due to anemia, but without jaundice. Multiple bruises are common due to thrombocytopenia, which causes increased bleeding tendency. Tachycardia is frequently observed as a physiologic response to anemia. Additionally, patients often appear cachectic and small for age if the diagnosis has been delayed. The typical presentation includes a combination of symptoms resulting from bone marrow failure, anemia causing fatigue and pallor, thrombocytopenia leading to bruising and bleeding, and neutropenia resulting in infections and fever. Let's look more closely at the common physical findings in pediatric leukemia. Most children present with a combination of symptoms that reflect bone marrow infiltration and failure. General examination typically reveals pallor, fever, fatigue, and weight loss. Skin findings include petechiae, ecchymosis, and multiple cannulation scars from previous blood draws or treatments. Lymphatic examination often shows generalized lymphadenopathy, with cervical nodes frequently being the most prominent. Abdominal examination reveals hepatosplenomegaly in approximately 70 to 80% of cases. Skeletal complaints like bone pain, particularly in long bones, may be present. Neurological symptoms such as headache and vomiting may indicate central nervous system involvement, which requires prompt evaluation. Let's consider our fifth case. A 7-year-old presents with pallor, petechiae, and abdominal distension. Complete blood count shows hemoglobin 7.5 grams per deciliter, white blood cell count 3,500 per microliter, and platelets 45,000 per microliter. Which of the following would be the most definitive for diagnosis? A. Peripheral blood flow cytometry. B. Bone marrow aspiration and biopsy. C. Lumbar puncture. D. PCR for fusion transcripts. The correct answer is B. Bone marrow aspiration and biopsy is the most definitive diagnostic procedure for leukemia. The definition of acute leukemia requires demonstration of greater than 20 to 30% blast cells in the bone marrow. While peripheral blood flow cytometry can be helpful and may show blast cells, it is not always diagnostic, especially in cases with lower peripheral blast counts. Lumbar puncture is important to evaluate for central nervous system involvement, but is not the primary diagnostic test for leukemia itself. PCR for fusion transcripts is valuable for risk stratification and minimal residual disease monitoring, but is typically performed after the initial diagnosis has been established through bone marrow examination. The bone marrow biopsy provides definitive morphologic, immunophenotypic, and genetic information necessary for diagnosis and classification. Let's review the comprehensive diagnostic workup for a child with suspected leukemia. The initial evaluation typically includes a complete blood count with differential and peripheral blood smear review. The confirmatory test is bone marrow aspiration and biopsy, where finding greater than 30% blast cells is diagnostic of acute leukemia. For proper classification, we perform flow cytometry to identify the cell lineage, along with cytogenetics, FISH analysis, and molecular testing to detect specific genetic abnormalities. Lumbar puncture is essential for staging to assess central nervous system involvement. Metabolic parameters including electrolytes, liver function tests, uric acid, and lactate dehydrogenase are important to evaluate for tumor lysis syndrome, which can occur either before or after starting chemotherapy. Additionally, coagulation studies are critical as approximately 10% of patients with acute leukemia have disseminated intravascular coagulation at the time of diagnosis. For our sixth case, an 8-year-old girl presents with fever, fatigue, and bone pain. Her complete blood count shows pancytopenia. Which laboratory finding is most concerning for tumor lysis syndrome in this patient? A. Serum calcium 7.8 mg per deciliter. B. Serum phosphorus 6.2 mg per deciliter. C. Serum potassium 3.8 milliequivalents per liter. D. Serum sodium 138 milliequivalents per liter. The correct answer is B. Serum phosphorus of 6.2 mg per deciliter represents hyperphosphatemia, which is a classic finding in tumor lysis syndrome. Tumor lysis syndrome is characterized by a tetrad of metabolic abnormalities: hyperkalemia, hyperphosphatemia, hypocalcemia, and hyperuricemia. These occur due to rapid breakdown of malignant cells, releasing their intracellular contents into the bloodstream. In option A, the calcium level of 7.8 is slightly low but not significantly decreased, as would be expected in severe tumor lysis syndrome. Option C shows a normal potassium level, whereas tumor lysis typically causes elevated potassium above 6 milliequivalents per liter. Option D shows a normal sodium level, which is not typically affected in tumor lysis syndrome. As noted in the provided information, tumor lysis syndrome can occur either before or after starting chemotherapy, especially in patients with bulky tumors. Let's examine our seventh case. A 10-year-old boy is diagnosed with B-cell acute lymphoblastic leukemia. Which molecular testing is most important for determining his treatment protocol and prognosis? A. Next-generation sequencing panel. B. Testing for Philadelphia chromosome, also known as BCR-ABL1. C. BRAF mutation analysis. D. FLT3 mutation testing. The correct answer is B. Testing for the Philadelphia chromosome or BCR-ABL1 fusion. is most important for determining treatment protocol and prognosis in this case. The Philadelphia chromosome results from a translocation between chromosomes 9 and 22 and is a critical prognostic marker in pediatric acute lymphoblastic leukemia. Although it's present in only about 3 to 5% of pediatric all cases, compared to 25% of adult cases, its presence significantly alters treatment. Philadelphia-positive all requires specific treatment protocols that include tyrosine kinase inhibitors like imatinib in addition to conventional chemotherapy. Without these targeted therapies, Philadelphia-positive all is associated with poor outcomes. Next-generation sequencing panels can provide additional information but are not as immediately actionable. BRAF mutation analysis is more relevant for solid tumors, while FLT3 mutation testing is primarily important in acute myeloid leukemia, not typically in all. Moving to our 8th case. A 6-year-old boy is newly diagnosed with standard-risk B-cell acute lymphoblastic leukemia. What is the typical duration of the first phase of treatment, known as induction of remission? A. 1 week. B. 4 weeks. C. 8 weeks. D. 16 weeks. The correct answer is B. The induction phase of treatment for standard-risk B-cell acute lymphoblastic leukemia typically lasts about 4 weeks. During this phase, the goal is to rapidly eliminate the majority of leukemic cells and restore normal hematopoiesis. As noted in the provided information, standard induction regimens include vincristine, prednisone or dexamethasone, cyclophosphamide, and possibly an anthracycline such as daunorubicin. The success of induction therapy is measured by achieving complete remission, defined as less than 5% blasts in the bone marrow at the end of induction. More than 95% of standard-risk patients achieve complete remission after induction therapy. This initial phase is critical as it lays the foundation for subsequent treatment phases and has significant prognostic implications. Let's review the complete treatment protocol for childhood acute lymphoblastic leukemia. Treatment consists of 4 main phases. First is induction, lasting about 4 weeks, which aims to achieve remission. This is followed by consolidation, which targets any residual disease and includes central nervous system prophylaxis to prevent leukemia from spreading to or recurring in the brain and spinal fluid. Next comes intensification, designed to further reduce any minimal residual disease that might persist. Finally, there's maintenance therapy, which typically lasts 2 years for females and 3 years for males, involving daily oral chemotherapy to prevent relapse. As mentioned in the provided information, this includes medications like prednisone, vincristine, methotrexate, and mercaptopurine. The total treatment duration ranges from 2 to 3.5 years, depending on risk classification and gender. Throughout this time, children will undergo regular bone marrow assessments, approximately every 3 months, to monitor for cancerous cells. For our 9th case, a 4-year-old girl with newly diagnosed acute lymphoblastic leukemia undergoes lumbar puncture as part of her workup. When is prophylactic central nervous system therapy typically administered? A. Only if CNS involvement is detected at diagnosis. B. All patients receive CNS prophylaxis regardless of CNS status. C. Only in high-risk patients. D. Only after bone marrow transplantation. The correct answer is B. All patients with acute lymphoblastic leukemia receive central nervous system prophylaxis regardless of CNS status at diagnosis. The central nervous system is considered a sanctuary site where leukemia cells can escape the effects of systemic chemotherapy due to the blood-brain barrier. Historical data shows that without CNS prophylaxis, 50 to 75% of children would eventually develop CNS disease. CNS-directed therapy typically includes intrathecal chemotherapy with agents like methotrexate or cytarabine, high-dose systemic chemotherapy with drugs that can cross the blood-brain barrier, and in some cases, cranial radiation. However, as mentioned in the provided information, cranial radiation is used more selectively in modern protocols due to its long-term effects, including restricted physical growth during puberty and potential development of cataracts several years after treatment. For our 10th case, a 7-year-old boy on maintenance therapy for acute lymphoblastic leukemia presents with fever and neutropenia with an absolute neutrophil count of 100 per microliter. What is the most appropriate initial management? A. Oral antibiotics and follow-up in 48 hours. B. Immediate hospitalization and intravenous broad-spectrum antibiotics. C. GCSF administration and daily CBC monitoring. D. Temporary discontinuation of maintenance therapy only. The correct answer is B. Immediate hospitalization and intravenous broad-spectrum antibiotics represent the standard of care for febrile neutropenia in pediatric oncology patients. Febrile neutropenia, defined as a fever with an absolute neutrophil count below 500 per microliter, is considered a medical emergency. This patient's neutrophil count of only 100 per microliter indicates severe neutropenia, putting him at extremely high risk for life-threatening infections. Empiric broad-spectrum antibiotics should be started within 1 hour of presentation and should cover Pseudomonas and other gram-negative bacteria commonly affecting immunocompromised patients. The mortality rate from untreated infections in severely neutropenic patients can exceed 50%, and any delay in antibiotic administration increases this risk. Oral antibiotics alone are inadequate, and while G-CSF may be considered as an adjunctive therapy, it is not the primary intervention. Simply discontinuing maintenance therapy without addressing the acute infection risk is dangerous and inappropriate. For our 11th case, a 9-year-old with high-risk acute lymphoblastic leukemia achieves remission after induction therapy but has minimal residual disease positivity. Which of the following is the strongest indication for hematopoietic stem cell transplantation in first remission? A. Age greater than 1 year at diagnosis. B. Initial white blood cell count greater than 100,000 per microliter. C. Persistent minimal residual disease after consolidation. D. Male gender. The correct answer is C. Persistent minimal residual disease after consolidation therapy is the strongest indication for hematopoietic stem cell transplantation in first remission. Minimal residual disease refers to the presence of leukemic cells at levels below microscopic detection but identifiable by more sensitive techniques like flow cytometry or PCR. Persistent MRD after consolidation is the most powerful predictor of subsequent relapse. Other indications for stem cell transplantation in first remission include Philadelphia chromosome-positive ALL that shows poor response despite tyrosine kinase inhibitor therapy, hypodiploidy with fewer than 44 chromosomes, induction failure defined as more than 5% blast remaining after induction therapy, and certain MLL rearrangements in infants. For our 12th case, a 16-year-old female successfully completed treatment for acute lymphoblastic leukemia 5 years ago. Which late effect should be monitored most closely in this patient? A. Growth hormone deficiency. B. Secondary malignancies. C. Anthracycline-induced cardiomyopathy. D. Cataracts. The correct answer is C. Anthracycline-induced cardiomyopathy should be monitored most closely in this patient. Anthracyclines like daunorubicin and doxorubicin, which are commonly used in all treatment, are associated with dose-dependent cardiotoxicity. This 16-year-old female has several risk factors that increase her vulnerability to cardiac complications. These include female gender, which confers higher risk than male gender, and treatment during adolescence, which is associated with greater cardiac sensitivity to anthracycline damage compared to treatment during earlier childhood. Importantly, cardiac effects may not become apparent until years or even decades after treatment completion, making long-term surveillance essential. Regular echocardiograms are recommended for survivors who received anthracyclines. While the other options are valid concerns in childhood cancer survivors, secondary malignancies typically take longer to develop, growth hormone deficiency would have manifested earlier, and cataracts are more specifically associated with cranial radiation, as mentioned in the provided information. Let's look at the comprehensive approach to survivorship care for childhood leukemia patients. Cardiac monitoring should include echocardiograms every 1 to 5 years, with frequency determined by the cumulative anthracycline dose received. Endocrine follow-up is essential to monitor growth, thyroid function, and gonadal function, particularly in patients who receive cranial radiation or high-dose alkylating agents. Neurocognitive assessment should evaluate academic performance, attention, and memory, especially in younger children who received central nervous system-directed therapy. Screening for secondary cancers includes regular skin examinations and, for those who receive chest radiation, appropriate breast cancer screening. Equally important but often overlooked is psychosocial monitoring, which should address quality of life, social integration, and mental health. The goal of comprehensive survivorship care is not only to detect and manage late effects, but also to optimize overall health and well-being in survivors of childhood leukemia. Moving to our 13th case. An 8-year-old boy relapses 18 months after completing therapy for B-cell acute lymphoblastic leukemia. Which factor is associated with the worst prognosis in relapsed ALL? A. Isolated extramedullary relapse. B. Relapse during maintenance therapy. C. Age greater than 10 years at relapse. D. T-cell immunophenotype. The correct answer is B. Relapse during maintenance therapy represents very early relapse and is associated with the worst prognosis in recurrent acute lymphoblastic leukemia. time to relapse is consistently the strongest prognostic indicator in relapsed all. Very early relapse occurring during treatment indicates highly resistant disease and carries the poorest prognosis, with survival rates below 30% even with intensive salvage therapy. Early relapse, occurring less than 18 months from diagnosis, also carries a poor prognosis. Late relapse, occurring more than 18 months from diagnosis, as in this case example, has a more favorable prognosis with survival rates of 50 to 70%. Isolated extramedullary relapse, particularly isolated CNS relapse, generally has better outcomes than bone marrow relapse. While age greater than 10 years and T-cell immunophenotype are adverse factors, they are not as powerful as timing of relapse in determining outcome. For our final case, a 12-year-old with refractory B-cell acute lymphoblastic leukemia is being considered for newer therapies. Which immunotherapy has shown the most promising results in relapsed or refractory pediatric B-cell all? A. PD-1 inhibitors like pembrolizumab. B. CD19-directed CAR T-cell therapy. C. Bispecific T-cell engagers like blinatumomab. D. Natural killer cell therapy. The correct answer is B. CD19-directed CAR T-cell therapy has shown the most promising results in relapsed or refractory pediatric B-cell acute lymphoblastic leukemia. Tisagenlecleucel, marketed as Kymriah, was the first FDA-approved chimeric antigen receptor T-cell therapy for pediatric B-ALL in 2017. This groundbreaking treatment has demonstrated complete remission rates of 70 to 90% in heavily pretreated patients who had failed multiple prior therapy lines. The therapy involves engineering the patient's own T cells to express a receptor targeting CD19, which is present on most B-ALL cells. While extremely effective, CAR T-cell therapy faces key challenges including potentially life-threatening cytokine release syndrome, neurotoxicity, B-cell aplasia leading to hypogammaglobulinemia requiring immunoglobulin replacement, and antigen loss resulting in immune escape. Blinatumomab, a bispecific T-cell engager, has also shown effectiveness, but with somewhat lower remission rates than CAR T-cell therapy. PD-1 inhibitors have shown limited efficacy as single agents in all, and NK cell therapies remain largely investigational. Let's explore the broader landscape of emerging therapies for pediatric leukemia. Beyond CAR T-cell therapy, the field is advancing rapidly with several promising approaches. Immunotherapies continue to evolve, with next-generation CAR T-cells designed to target multiple antigens simultaneously to prevent antigen escape. Bispecific antibodies like blinatumomab provide an off-the-shelf alternative to cell-based therapies. Targeted therapies include tyrosine kinase inhibitors for Philadelphia chromosome-positive ALL and BCL2 inhibitors that target specific survival pathways in leukemia cells. Precision medicine approaches now allow therapy selection based on comprehensive molecular profiling of each patient's leukemia. Novel combination strategies are reducing chemotherapy intensity by incorporating immunotherapy components. Ongoing clinical trials are investigating dual-targeting CAR T-cells and gene therapy approaches. These advances represent a paradigm shift from the traditional cytotoxic chemotherapy approach toward more targeted, less toxic, and potentially more effective treatments for children with leukemia. These advances represent a paradigm shift from the traditional cytotoxic chemotherapy approach toward more targeted, less toxic, and potentially more effective treatments for children with leukemia. As we conclude today's lecture on childhood leukemia, I want to emphasize how far we've come in treating this once uniformly fatal disease. From survival rates below 10% in the 1960s to over 90% today for standard risk all, childhood leukemia represents one of medicine's greatest success stories. This progress stems from advances in risk stratification, targeted therapies, and improved supportive care. Looking forward, immunotherapy, precision medicine approaches, and strategies to reduce treatment toxicity will likely drive the next wave of improvements. Remember that optimal care requires a multidisciplinary approach involving oncologists, nurses, psychologists, social workers, and education specialists. Thank you for joining today's Pediatric Case Review lecture. If you found this information valuable, please follow our YouTube channel for more educational content on pediatric oncology and other topics. If you have any questions, please leave them in the comments section below. Until next time, wishing you all the best in your practice with these challenging but increasingly treatable conditions.